Hi, my name's Simon Freeman. I'm an ENT consultant and cochlear implant surgeon in Manchester. And this video is just about magnetic resonance scanning of cochlear and auditory brainstem implants and the problems that can arise. So, the most important thing is that if you're going to scan one of these implants, you have to be absolutely certain you know what type the implant is, because unfortunately, some implants are fine and safe to put in an MR scanner, but some are conditional only under specific conditions, and some are actually completely unsafe to scan. And just to make matters more difficult, this is a bit of a minefield. There are a number of different types of hearing implant. And so before scanning any, you need to be clear on what type of hearing implant it is, because it may not be a cochlear implant or an auditory brainstem implant. And again, some are safe and some are not safe. And this is a continually expanding field. So whatever I talk about in this talk may become out of date. So always check with the manufacturer what the latest guidance is for a specific implant. So in this talk, I'm going to focus on these two, cochlear implants and auditory brainstem implants, and that's principally because they're the main problem areas with MR scanning. So you may already know what sort of thing a cochlear implant is, but I'm just going to cover the basics. Essentially, a cochlear implant has an internal component that's inserted surgically via a scar, an incision, and placed under the skin, and then the electrode is placed into the cochlea. In this internal component, the main body here is called the receiver stimulator, and this is the active electrode array. And then on one of the manufacturers, there's an extra electrode, which is just a ground electrode or reference electrode. And then there's an external component, which can take two different forms. This is the commonest form, where you've got a processor that has a power pack, and that looks a bit like a hearing aid and sits over the ear. And then you've got this separate area called the coil, and this has a magnet inside it. And the magnet attaches to the magnet in the receiver stimulator package over the skin. And so the two components can talk to each other. There are also external devices where all you have essentially is a coil that's thicker than this, and it contains the processor within it. And this is how the two connect to each other. And you can see the hearing aid part over the ear, and the coil is attached magnetically to the receiver stimulator package on the internal component. There are currently 4 different manufacturers for cochlear implants: Medel, Oticon, Advanced Bionics, and Cochlear. And while they all have some differences, they're all basically the same thing. You can see on the receiver stimulator package, the magnet placed in the middle and where the coil is going to attach to. The auditory brainstem implant only differs from a cochlear implant in the way that it attaches in the electrode array. So the cochlear implant electrode array is designed to curl inside the cochlea, whereas the auditory brainstem implant is designed to rest on the surface of the brainstem and stimulate that. But they both have the same type of receiver stimulator package that the electrode array connects to. And that means that essentially cochlear implants and ABIs are fundamentally the same with respect to MRI. And the only difference is the electrode array, which doesn't have any bearing on MR compatibility. And just to show you what they look like in reality, there are only 2 manufacturers for for the ABI, which are Medel and Cochlear. And here they are. And you can just see this is what the electrode array looks like with this little paddle on the tip of the array. So what are the main problems? Why is this a concern for us? Well, The original cochlear implants were not designed with MRI in mind, so they were never safety tested. And unfortunately, this means that they are considered unsafe by the manufacturers, and they should not be placed in the MR. Some have been safety tested, but only up to specific field strengths, and some have specific absorption rates and spatial gradient limits that need to be adhered to. So those are the MR conditional ones. Secondly, the magnet can be a significant issue, and I'm going to go on to that in a lot more detail, but there are a number of problems that can happen with the magnet. It can be very painful, it can displace from its housing, it can turn over, and in theory, it can demagnetize, although we've done a lot of these implants and we haven't come across that at all, and I'm not aware of anyone else that has. And then finally, the artifact. So the implant causes a significant artifact around it, and this needs to be considered if we're wanting to examine the adjacent head. And again, I'll show more detail on this later in the talk. So this is a slide that's been taken from Advanced Bionics and their talk on MR imaging. And this just shows the implant evolution from when they were first commercially available in 1995, right up to the latest generation in 2018. And of course, there are nice big boxes here that confirm that the early generations were not compatible. Then the next generation was compatible, conditional up to 1.5 Tesla. And the most recent, the most recent apart, the current one is MR conditional up to 3 Tesla, and the current one can be scanned with no problems. And this is a similar slide from the Cochlear Corporation. And again, you've got the very earliest device that was not compatible. You've got all of these middle devices that were conditional up to either 1.5 or 3 Tesla, and the latest generation can be scanned with no problems. So one of the big issues is what's happened with the magnet and how this has evolved over time. So once companies started to try and make their devices MR compatible, they sort of went down 2 branches. So Model stuck to fixed magnets that could not be removed, but that also means that they're not displaceable within the scanner. So although the artifact is fixed, these are relatively safe. Whereas Cochlear and Advanced Bionics went down the route of the surgically removable magnet, and they created these housings made of a silicon ring, so that surgically it was easy just to flip the magnet out, send the patient off for the scanner, and then take the patient back to theatre and replace the magnet. And then most recently, special technologies have been developed that allow MR compatibility with no problems. And that essentially falls to the rotating magnet. I'll come on to that in a second. The only difference is that Oticon's current generation is MR compatible. What they've done is they've got essentially what is a fixed magnet that can only be removed surgically by unscrewing it. So it doesn't have the same problems as the displaceable magnets that are in the silicon rings. So this is what I mean by the rotating magnets. So the latest generation, Model Synchrony, the Cochlear CI600, and the Advanced Bionics Hi-Res Ultra 3D. So Model has a special rotating magnet that can only be removed surgically by lifting the whole receiver package and coming in underneath it and pulling the magnet out. So it's not displaceable during a scan. Cochlear have this sort of cassette that, again, you can pull out surgically, but it's not displaceable. And then Advanced Bionics still have the silastic ring, but they've gone for magnets that are actually rotating in 3 different dimensions. And that means that they create much less torque. Now, we have experience with the Medel Synchrony and the Cochlear CI600, and I can certainly confirm that we've had absolutely no problems with those patients. They don't have pain, and they don't get displacement, and they do not need head wrapping. We haven't tried the advanced Bionics Hi-Res Ultra 3D, but certainly the company have confirmed that they do not need a head wrap and should be safe to scan. So the main problem, as I've mentioned earlier, is the implants that have the silastic ring, because those magnets are easily displaced from the force of the MR machine. And although they were designed initially to be surgically removed, we've now moved on to that, and we've created this way of holding the magnet in place using a tight head wrap bandage. And unfortunately, that means that sometimes these magnets can move, and they can sometimes flip over. One of the first ones that I head wrapped, we found afterwards that the external coil wasn't attaching, so we thought that it had become displaced, and we ended up operating on it. But then it transpired when we operated that the star that should be visible, denoting which side of the magnet is lateral, should be face up, was not visible. So actually what had happened was the magnet had rotated in 180 degrees. And then all we did was rotate the external magnet, and that allowed the two to connect to each other. The other issue with these silastic rings is they're very prone to pain. And we've had a number of patients that were simply unable to tolerate the scan because they found it too painful. And so as part of the head wrap procedure, we will usually use local anesthetic. The patient does have a choice, and they can elect not to have the local anesthetic injection. We have had some patients get through that okay, but it's quite common for them to struggle. So we do usually use local anesthetic with these particular devices. There are a number of different ways of holding the magnet in place. This one on the left is what we use in Manchester. So otoform is what you make hearing aid molds from, or impressions rather. So you mix the white and the green material together, and that's a soft, pliable material. And then we can press it over the implant so it fixes in place very nicely and it molds to the implant. And then over 2 or 3 minutes, the material goes hard and becomes basically like a firm rubber, and it's then immobile. And then a tight bandage over the top keeps it in the right place. Other centres have used plastic cards, which they place over the implant. We stopped using that because we found it was too easy for it to move when we were trying to wrap it. And then this is what Advanced Bionics recommends. So this is essentially like the coil that they use for their implants, but it doesn't have a magnet in it. And they actually insist that that is what's used on their implants. And they have told me in the past that if you don't use this specific device, you can affect the warranty of the device. The Cochlear have now brought out a new one as well, which is a disc with a magnet inside it, and that allows the magnet to easily connect and fix to the internal device. So it's much easier to get it to hold in place. The problem with that is it creates much more artifact, and therefore it's not suitable for head scans if you're trying to see anything within the head. But it is potentially suitable for the rest of the body. So the other issue is the position of the implant with relation to the scan. So as, rather, just stepping back a bit, so the greatest point of torque going in on the MR scanner is just outside the scanner, and that's sort of shown by this image. So it's this area just outside the scanner. So inside it's shielded, and then outside it gets gradually weaker the further away you move from the scanner. What that means is that as the patient is going into the scanner, the point at which they have the biggest chance of displacement or pain, if we're scanning the head, is as they move into the scanner. So we tend to lie them on the table and we put them into the scanner very slowly. The other issue, of course, is that if you're not scanning the head, if you're scanning, say, the lower limb, what happens is the lower limb is inside the scanner and the head is left within this vulnerable position. And therefore, we're particularly careful that if we're doing other parts of the body, we limit the scan time, because the longer a device is left in this strong area, the more chance there is of the magnet becoming displaced. So what do you do if there's a magnet complication? Well, the first thing to do is have a feel of the device. Does the magnet feel like it's in the right place? It should feel fairly flat. It's worth having a feel before they go in, so you know what it feels like. And then try and attach the external component. And again, that should just attach nice and easily. If there's a problem with either of those, or there's any concern about significant pain or anything like that, then it may well be worth getting an X-ray. And I've shown 3 X-rays here. So the X-ray needs to be tangential to the skull going through the implant. So the implant needs to be flat, as demonstrated on this upper picture. Okay. If the implant's sort of twisted, it's very difficult to tell whether it's in the right place. And here you can see one that's partially displaced and one that's completely displaced. Now, it is possible to push an implant and push a magnet back in. When we put them in surgically, what we find is if you can get the silastic in about 2/3 of the way round and then you push on it, that last little bit of silastic flips up and then holds into the right place. And that therefore can sometimes be done when the magnet's only partially displaced. So for this one that's fully displaced, there is no way that can be pushed back into place. You simply can't get it under the silastic ring. But for this one, part of that is still going to be under the silastic ring. So if you can push it and hold it there for 30 or 40 seconds or something like that, you might find that the silastic flips out. Now, if you haven't used local anesthetic, that's going to be far too painful for the patient. But if it's got local anesthetic, they may well tolerate that with no problems. And then finally, with flipping, as I said, some of the external coils have magnets that can be turned over. Some of them don't, and therefore that magnet would need to be surgically removed and replaced. But if you can turn over the external magnet, then that's a simple solution to the problem. So finally, coming on to artifact. So the reason that the magnets were designed to be removable was because of what I'm showing here. So this is from the Cochlear Corporation's booklet on MR scanning, and you can see that they describe artifacts with magnets in situ and magnets removed very differently. And presumably that's what they found experimentally. Unfortunately, what we found doesn't match up with that. So this gives you an idea of the sort of artifact you get with the magnet in place. This is an axial scanner next to the implant at the point of maximal artifact. And you can see that it's roughly about 50 by 70 or 80 millimeters in dimension, that sort of semicircle of artifact. And if we move on to other planes and other areas of the head, you can see this is the point of maximum artifact, but actually we can see the skull base and cerebellopontine angles in these 2 different patients very easily. And it's only really at that point of maximal artifact on the parietal lobes that there is a problem. And this shows the coronal scans again. It looks fairly similar, although the artifact ends up it's sort of almost like two different semicircles, but again, a similar localized artifact. When we have the magnet removed, unfortunately, we've not found that the artifact lessens at all. And here you go, this is an example of that. So what you see is, although there is some image within that semicircle, sort of there's some grey area of the brain, it's not actually, the definition is not good enough, so you can't actually tell what's going on there. So the overall artifact is more or less the same. And so we concluded that actually there's not a lot of point in removing a magnet to try and improve image quality. Unfortunately, it just doesn't seem to work like that. Another issue is that sometimes we see excessive artifact, and you can see on this patient we seem to have these sort of waves of artifact passing out across the head that's obscuring not only the area adjacent to the implant, but a significant amount of area on the contralateral side of the head. But what we have found is that this seems to partly relate to the plane of the magnet with respect to the plane of the scanner. And therefore, if you do find that you've got these large artifacts, it might be worth repeating the sequences, but just getting the patient to just rotate their head by 15 to 30 degrees. And you might find that significantly reduces the artifact as demonstrated here. So in conclusion, it is absolutely essential to know the precise make and model of the implant to be scanned, to know whether it's safe, conditional, or unsafe. What's the magnet like? Does it need a head wrap? Will it need local anesthetic? And you're going to have to make sure you have the most up-to-date information from the manufacturer with regards to specific devices. And then really, you need to be developing protocols. So you need to be clear on what scanner sequences and limitations are required, what scan time limits are. There needs to be a consideration to consent. There is a risk to the patient from displaceable magnets that must be consented. They must understand that there is a risk to their implant. There is a risk that they might need further surgery because of that. And also then to discuss the need for local anesthetic, head wrapping and splint, and also finally to consider the artifact. There's no point doing a head scan if you're not going to be able to see what you want to see. So, you know, although in an adult, a lot of that head is visible, if you take a child with bilateral implants, there's very little that can be seen beyond the artifact, and you need to bear that in mind. And that's the end of my talk. I hope you found it helpful. Thanks.